Good afternoon, everyone. Welcome to the UBC Learning Circle. My name is Crystal Morris. I'm the Aboriginal Education Coordinator for the University of British Columbia, and we are in the downtown office down on Hornby and Davie Street. And I'd like to recognize the traditional territory of the Musqueam, which this office currently resides. And today we're joined by the doctors, and I'll get to the introductions in a couple minutes. I would just like to go over a little bit of housekeeping, and just so everybody knows that we do record these sessions for future reference and for educational purposes, so that if anybody who missed the session would like to review and do some follow-up, or there's communities who wanted to participate that couldn't participate, they have access to these, and they are posted on our UBC Learning Circle website. So please do have a look at that, and please do have a look at some past sessions if you've missed anything in the past. In addition to that, in our room today, I'd like to thank Catherine Berry. She is Catherine, can you give everybody a wave? She's done a lot of support and upgrading of our systems and the registration, and has been a fabulous technical support. And we'd like to do a quick intro of the rooms. So Chief Kit, can we start there and then rotate around the screen? So if you could just tell us how many are in the room, because we try and capture the amount of participants in each of the rooms. So if you could just turn your mic on really quick, let us know who's in the room, and let us know how many participants. And for Adobe Connect users, if you could let us know how many people are in your room, because we do have 42 on Adobe Connect, and we have 6 participants by video conference. So let's start with Chief Kit down there in the left bottom corner.
Franny, Alec, Health Manager, Vanessa Tavarj, Medical Clerk. Just the two of us.
Thank you, Franny. Welcome. And over at the BC eHealth office.
Hi, there's 9 of us over here. And we're First Nations Health Authority and FINI staff.
Thank you. Welcome. And the next, I don't see anybody in Akiskanook, but you might be off the monitor right now. Akiskanook over on the east side of the province. Okay, let's go up to Lake Babine. See, we have a room and it's dark.
This is Lake Babine. Hello, this is Lake Babine. There's 2, and we initially had this room booked for the morning, but we're double booked now, so it's kind of busy in here, and we're still participating in it. Thank you.
Thank you for your participation. And I'm not sure who's in the dark room. Like you probably have sound, but you don't have video picture. So if you could just let us know, you could probably see us, but we can't see you. Blueberry First Nation, and anybody else that I have missed. So just feel free to.
Kaloa Adel here at Stolo Nation Health.
Welcome. Thank you. So what I'm going to do is just remind people in the video conference rooms, if you have questions, if you can actually just kind of wave your arms at us, and then one of the speakers will actually call on your question, and then you'll be able to ask your question or have your time for comment. For the Adobe Connects, if you could type your question into the chat room, I will be here moderating in the room. I will relay any questions or comments to the speakers. And yes, so I'm actually going to jump to the introductions. And the biography. So thank you very much for joining us today. I really appreciate the coordination and you taking some time out of your busy schedules and knowing how busy you are. Dr. Naomi Dove is the Director of Health Promotion and Prevention at the First Nations Inuit Health Branch here in Vancouver. Naomi is originally from the rural Western Ontario, but has lived here in BC since 1997. She completed her medical degree in specialty training in public health and preventative medicine at the University of British Columbia, which included 2 years of clinical training in psychiatry. Her portfolios at FINI include early childhood development, chronic disease and injury prevention, and mental health and wellness. She is very excited to be involved with the transition of the First Nations Health Authority. Dr. Isaac Sobel graduated from Queen's University Medical School in 1985. His first job was working as a family physician in the Métis community of
Isle La Crosse
in Saskatchewan. From there, he went to work for the Nisga'a Health Board as family physician and medical officer of health. He lived in the Nisga'a community of New Ayanish for 7 years. He then completed a residency in community medicine and obtained his degree at UBC. His next employment was at the UBC Faculty of Medicine, where he was Director of Division of Aboriginal People's Health. Yes, that's right. He accepted the position as Chief Medical Officer of Health from Nunavut in 2005 and remained in that position until 2011. Dr. Sobel served on the advisory board of the Institute of Aboriginal Health for 2 terms, and he has been a member of the advisory board of the National Collaborating Center since its inception. Currently is the Acting Director of Health Protection for the First Nations and Inuit Health Branch here in Vancouver. And our third doctor here joining us today is Dr. Shannon Tanya Waters. She is Coast Salish physician and is a member of the Dominus First Nations on Vancouver Island. She worked as a family doctor close to her home in Duncan. Then after 2 years in family practice, Dr. Waters returned to school and completed her specialty training in public health and preventative medicine. Dr. Waters now works as the Director of Health Surveillance at the First Nations Inuit Health Branch here in Vancouver and is involved in First Nations Health Information Governance, e-health, and is excited to be involved in the formation of the new First Nations Health Authority. So just a little bit about the agenda for today before I turn the table over to the speakers. There has been a little bit of a change in addition to the agenda. In addition to the speakers talking about their roles that they have with this new transition, they will also be doing the youth suicide prevention and response to mental health presentation. So just so people are aware, there's been a little bit of a change in the agenda. So what I'm going to do now is turn the floor over to the doctors. Welcome to the UBC Learning Circle, and okay, go. Welcome.
Thank you.
So thanks, Crystal. And I think at least for some of us, we haven't presented in this format before. So it's interesting what we can do with technology. And we have some of our friends and colleagues here physically in the room with us, and some we can see you through the video conference. And then we know some of you are with us on the web as well. I guess it was maybe a few weeks ago to a month ago or so that people that we had worked with had suggested that maybe we use the Learning Circle to just get to know the people in community better, and for them to get to know the physicians who work at First Nations Inuit Health Branch. Some of us have been here a bit longer than others, but none of us more than 5 years. I'm actually the old timer in the group now with 4 years at First Nations Inuit Health. So we thought the Learning Circle would be a good opportunity for us to just get to know the who's out in community better, and for you to get to know us better, and if you had any questions, to talk to us about our roles, our specific areas of work we have right now, and also there is some opportunities for that to change moving forward as well, and what kind of things would the communities like to see people who have, you know, training and positions such as ours in the new First Nations Health Authority working on. So one topic that we know has been of some priority for certain communities, certainly not all, is something that I think probably nearly everyone in this room and on the phone and on the internet probably has had affect them at one point in their lives, is mental health and suicide. And I just wanted to take the moment to recognize that you know, this is a heavy topic. It's you know, it's about real people that we're talking about, real people who are in some of our lives and maybe aren't here in the physical sense anymore, but that we know it's something that's a priority, and we want to help prevent you know, suicide in our communities in the future. So we thought that was at least probably one area that we could collectively work with our communities on moving forward, and prioritize that a bit more, and make you know, the response that we can help support communities if needed a bit more streamlined at the times when people are dealing with this this difficult area. I don't know if either of you wanted to say any more on that.
Well, we've introduced this concept to the medical officers of health who work for provincial health authorities, you know, regional health authorities. In some parts of Canada, medical officers of health are involved in mental health issues, but that's the exception rather than the norm. And we think that mental health should not be left out of the role of public health physicians. So we've been trying to bring this idea forward, not only for the First Nations Health Authority, but also to get interest from medical officers of health throughout British Columbia.
So I think, I mean, we do have a short presentation that we brought forward to the Health Officers Council, which is a biannual meeting of all the public health physicians in the province. Because I think with this transformation to the First Nation Health Authority, it's a time of change and opportunity as well. And what we really want to know is, how can we support you better? What does mental wellness mean to you and your communities? And how can we as medical officers orient our roles so that we're supporting you better in community, so that we're responsive to and aware of the issues and can support you in achieving health and wellness. So we can quickly go over the presentation that I mentioned, but I think we want to leave the majority of the time for discussion and just to hear your voice and your input. Okay, so just in terms of the slides, is that? Yes, you've got it. Okay, we're just getting it set up. So in terms of what we're going to talk about, we'll just quickly talk about around the area of mental health and wellness and youth suicide prevention, because as Shannon mentioned, this has been identified to us as a priority from communities and from First Nation leadership, and also, you know, we've identified it within a group. We work, in addition to the three of us that you see here, we also work very collaboratively with the physicians in the First Nation Health Authority. So Dr. Sarah Williams and Dr. Georgia Kaiba, who's a naturopath physician who works with the First Nation Health Authority, and Dr. Sarah Williams is a family physician, as well as with Dr. Evan Adams, who's a Deputy First Nations Provincial Health Officer. And so all of this work that we're presenting today are the result of discussions that we've had collaboratively with that group. And again, we're very open and receptive to feedback. So just very quickly, you can go to the next slide, please. Just very quickly, we'll go over some of the current programming in youth suicide prevention that we have in Finney. We'll talk about some of the challenges and opportunities. We'll talk about a little bit about some of the unique role we thought we may be able to play and to support communities in responding to mental health emergencies, just in the same way that you might respond to an emergency of a, for example, for a fire or a flood, or even to a communicable disease event. So giving it that same sort of priority and importance, and coordinating a response that's appropriate to the importance of that issue. We'll talk a little bit about what role we potentially could play, and then hear from you around some input moving forward. So next slide, please. So basically, just for a brief overview, the current programming that we have under the National Aboriginal Youth Suicide Prevention Strategy is targeted towards First Nations youth on reserve who are aged 10 to 30, and it's oriented around 3 phases, sort of prevention, intervention, and postvention. So prevention to strengthen resilience of communities and individuals and reduce the risk of mental illness and suicide. Intervention to identify and treat individuals who may be at risk of suicide, and to intervene when unfortunate events are happening, and then also to support those who have been bereaved by suicide and support communities in the grieving and healing process. The goal is to reduce risk factors and promote protective factors. And then there's a range of activities that are currently supported underneath that program umbrella, including the ASSERT teams, which I'll talk about on the next slide, as well as a variety of community-based projects looking at increasing or supporting community initiatives towards wellness and health, particularly around connecting with traditional culture and building culture and wellness and resiliency in some of the work from a very early point. Sorry, I'll move to the next slide, please. So there are 7 ASSERT teams functioning in the province right now, serving 82 of the 203 communities, so approximately 40%. And the general model for the ASSERT teams is to have 1 paid coordinator who manages the team, and the rest of the team is made up of trained, locally based community volunteers. And the general activities of the ASSERT teams include establishing local protocols to respond to suicidal individuals or events, also to increase awareness and education around some of the signs and symptoms that may indicate that somebody's at risk, and then to work with the communities on community-based health promotion and mental wellness. There's a variety of activities that have been included under that, the last portion, including workshops to address grief and loss, some workshops to address self-esteem, resilience, and leadership with youth, for example, as I mentioned, connections with traditional culture and activities. But really, there's a broad range in terms of what communities have deemed to be important to them. And that's really one of the things, when we had our ASSERT coordinator gathering in the fall, that's one of the things we really heard very strongly from the coordinator saying, we want to really look at mental wellness, and we want more flexibility in how we adapt programming to our needs at the local level. So one of the things I think that we all want to hear is how can we support you in that journey? Next slide, please.
So this slide here is just a bit of a diagram about some of the conversations that we've started having at FNIB, and Naomi in her role has been really influential in getting some of those conversations started around the times that we do know that we have communities approaching FNIB about a crisis going on in their community. For the most part, we have strong communities with good resources, good health support staff, and hopefully most of the time, as we do see, people are things are going well and the community is functioning well, and there's a lot of resiliency amongst the community members. And that's the green box. Though occasionally what may happen is that, there's a crisis, maybe in an external situation, such as, a fire or a flood, something like Naomi had mentioned, or perhaps someone who is feeling suicidal or even a suicide attempt. And that can be a tipping point to the community, being beyond their normal capacity to be able to deal with the situation, and they're in somewhat of a, they're at risk of a crisis, or they're actually in a crisis. And we have had situations in the past, such as, my home community, Cowichan, had declared a public health emergency because of suicide last year. And that was really a recognition of the community that they were actually beyond their ability to cope just amongst themselves right now, and they were reaching out for help from other sectors. And at NIB, we do respond in those situations, but we know that it's definitely not as streamlined or as easy as it should be and could be for a community to get that support, especially when they're dealing with something difficult. So we've been gathering together as a group with the physicians, nursing, some transfer staff, and also staff in the mental health programs areas to start talking about how we can make that easier and quicker for us to respond to communities when needed.
We do have a question.
Yeah.
Vanessa, up with the ONA, asks what happens to the funding for the ASSERT teams when the transfer occurs?
Sure. So with all of the funding for the community-based agreements, each of the holders of the community-based agreements have been offered the chance to go through something called novation. So to basically change to sign onto a new agreement, changing the previous holder of that agreement, which is Health Canada, over to the First Nations Health Authority, and that funding will stay as it is for the next 2 years. And then after that point, I mean, that sort of aligns with the broader transformation into the First Nation Health Authority. So there's opportunities for discussions, particularly around the regional and mental wellness tables that are ongoing over the next 3 to 4 months and into that period beyond, for regions to have that voice and communities to have that voice into how they like things to look differently in the future or the same.
So this next slide here is another diagram, and it just talks about some of the challenges and opportunities we have in this area and in other areas moving forward. And one thing I think that Naomi had mentioned earlier was that there's certain responses, say for like fires and floods, or say for instance when things such as communicable diseases occur. So one particular time when there was an emergency around communicable disease that's in the not too distant past is when we were dealing with H1N1, which I mean many of you around this will remember very well that time. And one thing that we were able to do during that time, because of the emphasis and the the acuity of the situation happening, was really to coordinate that response across local, regional, and provincially for what might be going on in First Nations communities. And so, I mean, there was regular teleconferences with people from all those different sectors, and it was really, I think, a time when, the physicians, so myself and Dr. Evan Adams were around at that time, really, able to hear like what the concerns were coming up from the communities and to be able to try and help navigate the response throughout all those systems to help the communities. So, I mean, this diagram here is just showing that coordinating that emergency response from the local to the regional and the provincial area is one of the challenges, and also improving health surveillance. Now, surveillance being looking at data about, diseases or things such as, suicide attempts, and seeing what's at the local, regional, and provincial areas as well. And so often what we find when something such as suicide has occurred, that there is no way for that type of information to actually get to the physician team at FNIB, and so we often hear perhaps a while after the fact, and if there was better streamlining of data, perhaps it would be possible to respond quicker to be there for the community if needed. The bottom two arrows are just showing kind of the opportunities. We've really heard, as Naomi mentioned, that the communities want a holistic wellness approach promoted, and so we want to make sure that what we're suggesting or how we work together allows that to continue as well, as also at the same time increasing the community and the system capacity to deal with the challenges and opportunities that are coming up. Next slide.
So this slide you see, it talks about the presentation that we gave at the Health Officer Council that was mentioned before, responding to suicide clusters. So that means perhaps a few suicide attempts or actual completed suicide in the same or neighboring communities. So there can be a short-term suicide crisis response, and we would hope that in our roles we could, in fact, contribute to the coordination of that type of response. At the moment, in my role as the Acting Director of Health Protection, a part of the portfolio is emergency preparedness and response. And as Shannon said, mental health issues and suicide issues in communities are just as much a crisis as a physical disaster, let's say, or emergency, such as a flood, a fire, an earthquake. So we feel that there should be the same magnitude of response to assist the community with their dealing with this kind of situation. So we propose that in the short-term response, there should be one major player or principal contact that a community could get in touch with. We don't know who that would be, but it could be the Director of Health Protection. And that person's role would be to gather together a multi-agency group to go to the community and respond quickly. And that means before that event takes place, you have to build that team, and people have to know each other and be prepared to assist at short notice. With medium-term response, Naomi Dove's area deals with promotion and suicide prevention planning. So that would be another aspect, not just this. In emergency preparedness, we call this term mitigation, trying to make things better before any crisis happens. So if you can build community capacity, if you can have programs of mental health promotion, mental wellness promotion, you might be able to actually stop suicide behavior or suicides well before they might have occurred. And then Shannon mentioned that her role is the Director of Health Surveillance, and as she said, in order to have good information, you have to have a good data system, and if we knew much more closely what the situation is in different communities with respect to mental illness and suicide, we might be able to have earlier interventions. So that's kind of reiterating some things we said before, but I hope this doesn't leave you with many questions, although feel free. There is a question already we're seeing.
So there's a question on Adobe Connect from Sandra, and she states, my apologies for getting into the session late. So she said the number of communities that have supports total 82. I could not tell by the map alone if the Northeast had this support in place. If so, is there a contact for the hub or the health directors in this area to that link too? So I think it's just connecting the services to the communities. Sandra, did I state that message correctly, the question you were asking?
So we'll certainly, I can have, we do have our contact information at the end of our PowerPoint, and that's certainly a question you can direct towards me, and I'll connect you with our Youth Suicide Program Coordinator, because we do, depending on which community, we do, a number of the teams do service a number of communities in the area, so to provide you with more specific information, if you want to connect with me afterwards, we can, I can address your question more fully.
Okay, next slide. You can take this one.
Sure. So again, this is talking about those steps of an emergency preparedness response. And so basically, Naomi had talked earlier about the prevention, intervention, and postvention response to suicide emergencies. And what we were actually looking at here potentially is, like Isaac was saying before, is treating mental health emergency like an emergency such as a fire or flood and giving it that same importance. And the steps in that to deal with those types of emergencies typically is what you see here in this diagram: prevention or mitigation, preparedness, response, and then recovery. And when you're looking at a response to emergencies, typically it has a really high emphasis on that intersectoral and interagency activity, which is something I think that we have the opportunity to make sure that happens a lot more moving forward with the First Nations Health Authority. It's something we need to improve on and how we responded from FNIP to this type of situation. There's consistent reevaluation and updating, and then it's also being responsive to the community resiliency. We do know and we have seen that our communities deal with difficult situations and take the appropriate time they need to have some recovery from that, and then learn from that and are resilient moving forward.
And as you see in the diagram, it's a continuous process. One event in a community doesn't mean that the system gets activated and then it gets disbanded afterward. It's a continuous process. And part of the biggest efforts that can enter into the picture is actually the prevention aspect of it. So we would hope that communities could utilize whatever services or abilities we might have to work on prevention, but also that we'd be very much available at the time of a crisis. So the response would be fast, the response would be appropriate, the response would be multi-agency, and people wouldn't just disappear after that, but we'd also be involved in the recovery phase.
And I'd say that actually, there was a lot of good things that came out of our experiences with H1N1. There was a lot of good processes that were set up, but unfortunately, I think what we found in some cases is that regular communication and that interagency communication and that emphasis on getting together to talk about the problem that was there at the time has kind of been lost a little bit in the years that have gone by since H1N1, and we really wanted to take our learnings from there and extend it in other areas such as mental health.
So in terms of, I think as we had described at the beginning, one of the things that we really wanted to get out of this presentation is to hear how we can support you. So as we mentioned, we're all physicians with specialized public health training, and potentially some of the ways we could support you we've outlined on this slide. Around Shannon's role around health surveillance, which is to conduct basic health assessments to help with gathering information during mental health emergencies, and to measure and evaluate the impact of programming, so to determine what works, what works well, and what examples we can, what programs we can use as examples to build on in the future. Some of the things that potentially we can do within health promotion to help support you are to look at more upstream holistic approaches. So how can we look at, for example, maybe we want to address the issue around mental wellness and suicide prevention, but maybe actually where we need to start is with our early childhood development program. So how do we support communities and families into creating strong, healthy environments for kids and providing children with all the opportunities that they need moving forward. So, and that's really one of the things I think that we've heard from some of the leaders within the public health field as well, is that the First Nations Health Authority can be a real leader, and First Nations communities can be a leader for the rest of the system in having a more upstream, holistic health promotion oriented health authority that focuses on wellness. And that's something that Dr. Perry Kendall, who's the provincial health officer in BC, has, we're really looking to you to you as a First Nation Health Authority and communities to show us how to be effective at acting on the social determinants of health, of looking at the model of wellness and how we can start to change our ways of practice within the broader system. Just something else that you can assist with in terms of health promotion is looking at creating and evaluating new approaches or applying and adapting effective practices. And then also one thing that we'd like to do as well is support the building of community capacity, because I think what we found is the best solutions are often those that are locally derived and sustainable. So how can we support you with that goal in mind? And then Isaac had already talked a little bit about the emergency response, so looking at the communication, collaborating between sectors, because there's often so many different jurisdictions and actors involved. So how can we support you in some of that complicated kind of coordination and having timely responses? I think I'll pass it back to Shannon for our last slide.
So yeah, so basically, I mean, this is the last slide we have before we hope we can have just more of an open discussion. But I mean, right now, our path forward has some of these steps within it. As I said earlier, we really have taken the direction that we're going to prioritize mental health and wellness, and that's something that we knew from current experiences as a group, that we have also heard from a number of communities. And so we wanted feedback from people here today. Does that seem like a reasonable area for us as public health physicians to prioritize? We thought that as public health physicians becoming medical health officers within the new First Nations Health Authority, that one of the ways we could support you is by providing some leadership in responding to mental health emergencies and suicide prevention, and that knowing that those roles would include, really bringing up that intersectoral coordination. Myself, right now, currently with my role in health direction, so getting the information that's needed at the time, and that information that could also help inform some of the policy and program planning, especially in Naomi's area, which covers mental wellness. And then also, one of the roles we could play is helping, as Isaac was saying, to align and coordinate public health and mental health service delivery. And one thing that's been really helpful for us as we're, in this time of transition right now, and we actually did receive our reasonable job offers from the First Nations Health Authority as recently as yesterday. And so our jobs are more and more becoming, I think, what for all of us is more exciting in terms of our day-to-day work, and more aligning to the diagram we have here at the bottom of the slide, the wellness model. And really, how can we look at our roles in taking all these aspects in the wellness model into consideration? And I think one thing I can also say is that we do have specific roles, Naomi health promotion, myself health surveillance, and Isaac health protection, but that we really are working together as a team. And that's why we wanted to present jointly around this area of mental health, even though it's Naomi's area, because we know it's a very high priority, and often when things such as tragic events such as suicides are occurring, it's not one person or one community who's doing this on their own. It's through everyone working together.
I want to just add to Shannon's comment about the excitement of moving to the First Nations Health Authority. It reminds me of a comment that Richard Jock, who's the Vice President now in the First Nations Health Authority, said to us at the last Gathering Wisdom. He said this is going to be a huge shift, because when you worked for First Nations Inuit Health Branch, your job was to support the Federal Minister of Health. And when you work for the First Nations Health Authority, your job is to support First Nations communities. And that is really an exciting change. So this is one of the first times we've had to be able to connect with you in this way, to ask for your input, to see what you think about our proposed way forward. And if you think it will work, if you have other ideas about a path that you think would be more appropriate, we'd certainly welcome hearing from you.
I think, and then if you just, the last slide actually is just, all of our contact information, which I think, people might have otherwise, but I think we all really do, very much believe, yes, please certainly do get in contact with us. And I think typically speaking, I don't know if we've had the type of face with communities that we are hoping to have moving forward, and that people really do know our names, the areas that we work in, and that can feel comfortable for approaching us on, issues, especially when they're situations that might be of importance and spanning many communities.
So that has been a request from the First Nations Health Authority that as much as possible we get out to communities so we're not total strangers, and if we come in at a time of crisis you have no idea who we are or how you could relate to us. So we're open to invitations. Thank you.
We do have a comment on Adobe. Sandra states, am I correct in assuming the PowerPoint will be forwarded to us participating? Yeah. Is it okay to post that on the Learning Circle and forward that?
Yeah, and I think, I think it would be great if people took that material from the PowerPoint. I guess the only thing I would say is, like, these are ideas right now. It's certainly not, definitely the way that anything looks. It's just, amongst the physician group, we were talking about what, how we could support or respond. And so, I mean, it's certainly, if people wanted to take that look at that further and provide, comments, that would be helpful.
Yes. We've also presented this, by the way, at a meeting of, I forget what the whole thing was called, but there were people from Ottawa there. What was that group called? It was
Tripartite Committee on First Nations Health.
Oh, Tripartite Committee. There were more people in suits and nice dresses there that I've seen in a long time. So we haven't just shared this idea with folks at the Health Officers Council, but I want to reiterate what Shannon said. This is really not an official policy or direction of the First Nations Health Authority. This is a path that we've come up with and we've presented to the First Nations Health Authority, but please don't think of the slide deck as something that's an official document that reflects a decision made by the First Nations Health Authority. Far from it, and you're the ones who have to lead us to whatever decision is made.
And I guess at this point in time, I'd just like to say that we just held the regional sessions on the rollout of the mental health plans. And so regional sessions are being formed here in the next 4 to 6 weeks. So watch for advertising rolling out regionally by Blake Stillis. So, and everything seems to be fitting in pieces because Richard was on the UBC Learning Circle, and we've had the doctors here, and we've had the regional sessions for the rollout of A Path Forward. So for us to support the ongoing transition of First Nations Inuit Health to become a part of the First Nations Health Authority. So do watch for those presentations as well, because sometimes you may think you're getting bits and pieces, but the pieces will all fit together once we get those all up on the UBC Learning Circle and on the First Nations Health Authority website. So if you've missed those presentations on A Path Forward for your regional, for your region, just watch out for those, and they will hopefully soon be posted on the website so you can catch up to speed on the discussion that took place.
Thanks.
There is a question. How are you going to be collecting data and doing surveillance?
So that is a good question, and there's a number of different ways. I mean, data can be collected, and a number of different ways where data is already collected. So, I mean, currently we do have some suicide data, and that is because youth suicide is one of the indicators in the Transformative Change Accord First Nations Health Plan. And that data that we have is through a linkage of the First Nations client file with the vital statistics information that the BC government has. in order for that data to be created, it has to go through a governance committee to make sure that a linkage can occur, and then the linkage has to occur and the data come out. So all those steps mean that that data often isn't very current. It's a number of years old by the time that we do receive it, unfortunately, sometimes. And of course, that means it's not a very good type of data for responding in an acute situation. One reason why we've been talking to some other groups about this, as Isaac mentioned, the Tripartite Committee on First Nations Health and the health officers, and Naomi and myself were talking with some people who work in public health around injury prevention, is because there really is no way right now that information around intentional injury, such as suicide attempts or even a completed suicide, is collected kind of in a real-time situation right now. And so to have that type of data to inform on a short-term basis what's going on is one of the gaps that we currently have. And so when things like the public health emergency declared in Cowichan around suicide are declared, unfortunately it's often a while after the fact, and we're just as interested in the suicide attempts or the suicidal ideations as we are the completed suicides, because we would want to make sure that things are in place for interventions for someone who's feeling that way to have support. So really, one of the things we do have to work on moving forward is how do we get that type of information? Who holds that type of information? Like if it's at a community level, then it's the community's information, and they can respond and then reach out for more help if and when they find that's needed. So it's a bit of a number of different places that information can come from. But really, I mean, one of the things that we could have further conversations with health directors and communities around is this the type of information that you feel you'd want a bit of a better way to collect on, so that you could respond and we could help as medical health officers if needed in that response.
And one of the challenges, I think, is to get information that may not be an official documentation. Shannon talked about a situation in which someone might be contemplating suicide, and I've read some literature about communities in which there's been some training for community members to look for clues among their family or among their community members, which might alert them to the fact that someone might be contemplating suicide. We know that mental illness still is carries a stigma with it, so no matter what community you're in or what part of Canadian society you're in, many people, even if they're aware of mental illness in their family or community, don't want to talk about it. So that's a challenge for getting information. People have to be able to not feel ashamed, embarrassed about talking about these issues, but treat it as any other medical situation.
Hi, this is Berna Howard calling from the Northwest Community Engagement Hub. And I have a question with regard to the ASSERT program. What role does the medical health officer have to ensure that the ASSERT programs have the support of a clinician to work with them? Because right now there is a FAST program here in our area, but there is no clinician working alongside of the FAST program. And FAST stands for First Nation Action and Support Team with regard to the suicide awareness and prevention in the 11 communities in the Northwest.
So thank you for your question. That's a good question. Within the roles that are currently within the health promotion and mental health team at FNI currently, so we provide the program support. We have a clinical mental health consultant and a clinical nurse specialist in mental health. And they function really as a partnership in providing support to communities who are dealing with and managing mental health crises, and also in helping communities to assess what the resources and strengths and gaps are at the current time around mental health, but not just mental health, looking at other areas that impact that as well, such as education, schools, health services, policing. Like, how can we look at the whole environment to see where how we can sort of strengthen and support all the different sectors that may be involved in a mental health response, and also in mental health promotion planning moving forward. So we do have that support within our unit and available on an as needed basis. Obviously, there are only 2 people, so that there are some limitations in terms of resources there. But I think one of the opportunities moving forward into the First Nation Health Authority as well is that, the roles that we have, we're not direct clinical providers right now. We don't practice directly with patients. We practice more public health or population health. So we look at systems, and how can we look at the factors that make populations and communities healthy, and also those factors that may contribute to being less healthy and well. So what can we do? The approach that we take is we can help with some of the program planning directly and evaluating which programs may be useful in supporting that, but then also looking at that broader system to see where can we help advocate, and where can we help to sort of increase the voice and use some health information and statistics and arguments to help coordinate some resources around within the broader system. And I think there is an opportunity with the transition to the First Nation Health Authority to align and coordinate with the Regional Health Authority and with the province as well in terms of the direct service provision that's being provided. So to take a step back, and instead of having everything siloed in terms of on and off reserve, and these are programs that belong to the federal government, and these are programs belong to the regional health authorities, like how can we start to work together more effectively to support the community? So in terms of your actual question, I think that's certainly something that potentially, I think that feedback I can take forward, and we can start to look at how can we work more effectively with some of our partners who do that direct clinical service provision to make sure that the teams are supported and communities are supported, because we know that access to services is a big issue, and certainly shortages of both mental health counselors and also physicians are a big issue, particularly in some of the more rural and remote areas.
I'd like to add to that. I lived and I worked in the Northwest, and I certainly understand where you're coming from, because it was often the case that a community or a family physician would encounter a situation or a patient who needed specialized care, and that access to specialized care wasn't always easily available. So your question certainly makes sense to me, but one of the things the First Nations Health Authority is already talking about is how do we build a better system to have better access to all aspects of the medical system. So I think that's very much on the radar, that question, but please don't lose it. That's the type of thing to keep asking.
We have Franny. Franny, is that you? There's a
Yes,
question
it's
from
me.
Franny?
Can you hear me?
Yes, Kispigott, can I get you to mute your microphone? Franny has a question here.
Okay. I
There you go.
have. Well, first of all, I'd like to thank the 3 doctors giving us this opportunity to have the dialogue with you today. I think it's
happy card.
It's great that we're able to share and listen, and this is great to have this connectiveness and to have this kind of engagement. I think some of the questions I have, it's around the roles and the jurisdictional issues. I think we talked about this back in November when you had a presentation with the First Nations Health Directors Association, and I think the jurisdictional issue is something that's always going to be there, and until we have an idea of where the regional medical officers are with, like, what is their role as compared to the provincial part of it, like the regional health authorities, like for us, the Interior Health Authority? You're saying that you're not clinical advisors, and you're looking at the systems. So we at the community level need to know, when will that change? Is that going to be in the near future? Like for us, I think we need to start planning our work plans around these types of issues so as we're better prepared on how we're going to address and have that conversation with Interior Health Authority or the medical health officers. There's a lot of issues that we're faced with on a daily basis, like the communicable disease, like the advisories and the outbreaks. Are we going to be given advisories by the regional health authorities, or are we going to be getting them from the regional medical officers? But then you're saying you're not clinical advisors. So that puts us in a situation of who has the jurisdiction. And the consultation with the environmental health, the public health, with situations like safe drinking water, that's a major issue in our communities. Like, are you going to be in a position to give direction, to provide that support, give the recommendations to make improvements and changes? We need that liaison for Aboriginal and Northern affairs. So those are the types of issues that we're faced with. And I think with those in mind, we need to be clear on what is the strategy here, because we at the community level need to have that in place on how we're going to plan. How are we going to include this in with our community health plans, our nation plans, and so on. So, yeah, I have so many questions, but I think this is great that we're given the opportunity to hear this, and I really think it's exciting that we have our own regional medical officers, and you know, there's a lot of territory that's new territory that we're going to come upon. So thank you.
Could I try to answer some of that, or you want to start?
Well, sure. I think even if we had a room full of people, is it Franny? We probably have a difficulty answering this question, but I think you bring up really, really important questions. And these are the questions that people at tables that we're not sitting at are discussing, I think, you know, weekly or what have you. So part of what you're bringing up has to do with what's called order in council underneath the Public Health Act. And so public health typically is under a provincial jurisdiction, and while we have been federal government employees working often on federal lands, the reserves, that whole provincial legislation question has been very tricky, and what can often happen, I'm sure some on this call have had that experience, is things fall through the cracks. And so moving forward with the First Nations Health Authority, people have been paying close attention to our roles and what we could gain by becoming official medical health officers like our colleagues. We've always kind of been second-rate medical health officers in a way, because we don't have all the their powers isn't really the right word, but we don't have all the same jurisdiction because of legislation that our colleagues do. So people are very carefully looking at, okay, how about our medical officers within the First Nations Health Authority having that power underneath Order in Council, but in fact, does there need to be changes to the legislation in order for that to occur? And that also has implications for the legislation and the whole First Nations Health Authority in general. So it brings up very good points, and I know Isaac more intimately works on the areas like water, so...
Well, thanks, Shannon. At the moment, in health protection, I work very closely with our environmental health officers. So we work as a team, and we recognize that environmental health officers are probably, for many communities, the most visible members of the team, and they assist when there are water problems, and they come to your communities often. The First Nations Health Authority is thinking about how to deploy the environmental health officers after October 1st. There are different models in the province. And in some places, the environmental health officers report directly to a medical officer of health or to the chief medical officer of health. And generally, under British Columbia legislation, the environmental health officers have the authority to issue orders because they have a delegated authority that's delegated from the medical officer of health. That's what I did when I was a medical officer of health in Terrace years ago. It was through my delegation that environmental health staff could, issue orders. For example, they could go into a restaurant, and if they saw that they weren't following hygiene measures, that they might have procedures which could make people sick very easily, they could give them a warning, and if the restaurant didn't change its ways, they could even shut them down. Right now, the federal environmental health officers don't have that type of power. They work generally in the role of colleagues and advisors. And in fact, there's been some debate about, what would happen if they got the authority to actually issue orders? Would that change the nature of the relationship with First Nations communities? And the environmental health officers feel, in fact, that the relationship they have with communities has been very, very good, and they don't foresee many times at all when they would have to use that legislative authority and issue orders. So that's one part of it. They will still be available to you. They'll still be dealing with drinking water issues no matter what, and so will health protection. In terms of outbreaks, it's pretty confusing now who's responsible for what. There's supposed to be a list of communities who have named either a regional health authority or an individual medical health officer to be their provider of medical health officer services. And there are communities which haven't done that, and for those communities, we're supposed to be the medical officers of health. But from what I understand, those distinctions haven't been really kept up to date very well. So we have some regional health authorities, provincial health authorities, which feel like they go on to First Nations communities, that's their job. We have others who think it's not their job, and that's something that we're really going to have to work hard on to establish those boundaries and roles and responsibilities between our medical officers of health and the regional medical officers of health, so that you know who to call in case of a fire or a flood, or who to call in case of a communicable disease outbreak. So that also is in process, and it's a really good question because it's something that is of vital importance to get sorted out. So thanks for the question.
I also just wanted to mention, so we had presented our roles in relation to mental health and wellness, but I did want to mention in terms of our broader roles, our training and scope of practice is equivalent to the Regional Health Authority medical health officers. So we're the same types of physicians that they are, as Shannon had mentioned, that we're not sort of recognized under legislation right now in the same way under provincial legislation, and that hopefully one of the unique aspects that we'd like to have is that we'd like to be more responsive directly to First Nations communities and also to the priorities that are identified by communities. So rather than focusing maybe on enforcement, maybe looking at how we can be collaborative and also advocate within the broader system and the partners that you had mentioned, players such as ANSI and others, to make sure that issues are dealt with timely and efficiently.
Yeah, and when Shannon said we're not clinicians, the definition of that I understood was we don't do one-on-one work with patients. So you could say we're community health clinicians, but I guess it's a matter of definitions. Sometimes we think that a clinician is somebody who's like in a clinic dealing with one person at a time, and that's not our role, and that's not the role of regional medical officers of health. But as you know, I hope it's not too confusing. As Naomi said, we've got the exact same training and qualifications as the medical officers of health anywhere in the province.
Hi, this is Verna Howard again from the Northwest Community Engagement Hub. I have a question with regard to the emergency preparedness. Is the First Nations, well, right now in the communities in our area, we have the FNESC working with the volunteer fire departments, and ANSI provides funding for that also, for the volunteer fire departments to be in place. But I'm wondering, is the First Nations Health Authority looking at partnering with FNESC and ANSI to ensure that the on-reserve communities have their emergency preparedness planning and emergency preparedness response protocols in place?
Well, in health protection, we do have one position that has a principal responsibility of pandemic planning, but pandemic planning is a part of overall emergency preparedness. So we do try to work with communities already to improve or enhance or maintain their current emergency preparedness plans and activities. Also, there's a new committee that's being formed in British Columbia, which is the First Nations Emergency Management Committee, and that brings together federal officials, folks working in First Nations Inuit Health Branch, which will soon be First Nations Health Authority, the BC Emergency Services. We have a liaison with ANSI as well, and we're just getting together, we're just forming and getting together to work out everyone's roles and responsibilities and how we'll move forward in the future. So yeah, that area is under active discussion, and there's already some new good coalitions getting formed to deal with just that issue.
Okay, we do have a couple of comments we kind of missed back when there was questions around the ASSERT team. So Vanessa from the ONA asked, how can you support the ASSERT teams to assist in collecting data in a timely manner?
So that's a question I'm really glad to hear, because I think, so my role is right now is the Director of Health Surveillance at First Nations Inuit Health, but I work with a team of people in this area who are at First Nations Inuit Health Branch and also at the First Nations Health Authority. And there has been some importance in this area that's been addressed by the CEO of the First Nations Health Authority in getting teams of people together that can work with data. So some of those types of people are data analysts, some of those types of people are epidemiologists, people to input data and people to help with report writing or what have you around what the data would eventually tell. So that team is called the Health Knowledge and Information Team, or the HKI team. And so that team is one of the areas that the First Nations Health Authority is going to have moving forward, and how that team can support the regions, support different programs, support different teams, such as an ASSERT team, I think is a conversation that we can have moving forward. I mean, when you're looking at data, there's the issues around how you collect it, where you'd store it, how you'd analyze it, how you'd interpret it, and how you'd get the information out. So one of the things that team has really been looking at is, providing some, basic background information to communities or to ASSERT teams, if there's some interest there, on some of the basics of working with data and what kind of things would need to be in place to collect data and to use that data. So I think that's something that the HKI team and potentially the ASSERT teams could work on moving forward, and especially as the group of physicians collectively, including Sarah Williams, Georgia Kaiba, and Evan Adams, have said that mental health and suicide prevention area is something we really want to prioritize, that might be a good place to start.
So there's one more comment here from Sandra, and I'm pretty sure Sandra's from the north. So Sandra states, so a strong relationship between the Ministry of Child and Family is paramount. That's her comment.
Thank you.
Perhaps a way to comment on that is to talk about the strategic planning groups that have been going on now for quite a while, which have representation from the BC Ministry of Health and from the First Nations Health Authority and from First Nations Inuit Health Branch. Naomi might be more familiar with that exact area, but I know that there's been plenty of discussion and sharing of ideas between the BC Ministry and the individuals working to establish the First Nations Health Authority. In fact, sometimes it's been a very interesting conversation because there are ministry strategic plans and programs, and there's often very engaging discussion about whether the First Nations Health Authority wants to follow those plans or wishes to just use them as information to assist them in developing their own plans. So it's really a kind of a tricky situation in a way when you've had differing elements of the health system as individual entities, and now the whole idea is to have a tripartite engagement. So those discussions have been going on. I don't know, Naomi, if you have more about that specific area or not, but I think to give that general overview might be useful. What I've just said, I meant,
I think with and I'd like to hear more about that comment, actually. Be curious to hear more. But I agree absolutely that it's important to recognize and engage the different partners, especially the ones that are involved at the local level. One of the things that we felt maybe a potential role for us as medical health officers is being advocates for sort of cultural competency within the broader system, both within health services and others. I mean, we are aware of some circumstances in which there could have been more cultural competency in terms of the interpretation and also, management and how individuals and communities are dealt with. So potentially that's a area that we may be able to help advocate for. But I think certainly that's one of the things I was saying earlier in terms of looking at the community and doing an assessment and planning of the different actors, the sectors and organizations involved, and also the strengths and resources and gaps. Because I think the success of any plan in terms of mental health promotion and suicide prevention will depend on how those pieces are working together and making sure, again, that they're aligned around community needs and are responsive to and culturally appropriate to community needs.
So maybe I can actually assist, because I'm not sure, Sandra, if you were a part of the sessions on rolling out the plan of path forward, because they talked about the partnerships and the organizations they wanted in each of the individual regions who was going to be invited to those in-person sessions on rolling out a path forward. And I don't recall off the top of my head, because I think I missed the North session. I was actually away. If that was one of the organizations that they were going to invite to the table, but definitely it's a comment that we can forward to Blake so he can capture that in the invites for the regional session for the North. So I guess I was just trying to pinpoint from which region you come from, Sandra, so we can forward that comment to Blake and ensure that that is captured in who is invited to those regional sessions.
She's from Treaty.
She is from the Northeast. Northeast. Okay, we will ensure that that gets forwarded to Blake. That assists in any way.
Yeah, that's helpful. Thank you.
There is another question. Is there any questions in the video conference rooms? Because we do have another question here on Adobe Connect, but I want to make sure that we're inclusive of everybody who has questions. If there isn't, I will jump to this question from Peter, and he is asking, what are the communication policy protocols with community and regions when they are suffering with ongoing suicide?
I guess we can take a stab at talking about some of the communication protocols, but then, Peter, let us know if we're not on the right path with answering your question. I think one thing I'll just say to start off with is that certainly we're very sensitive to the fact that when a suicide does happen, that communities have mechanisms, support people, staff in place to deal with that, and that at certain times that perhaps the community can handle that situation on their own, and it's not necessarily given that that information needs to leave to that community, or that the medical health officers need to, like, you know, rush to that community. Like, it's definitely, I think that any communication that happens around that is first off approached from the community in terms of what they specifically need. And then in terms of, you know, what we're talking about, getting data in the bigger picture to help inform things moving forward, that would be done with careful consideration of, you know, confidentiality, privacy, who needs to be in which loops for what types of response, and you know, making sure that information also isn't, you know, potentially out there to be used for interpretation that could lead to such things as stigmatization. So those are a number of the things that we always keep first and foremost in our minds, and then also within the First Nations Health Authority, and well, we do have a communications department within Health Canada as well, but one of the areas of building relationships we've talked about as medical health officers is with the communications department within the First Nations Health Authority. And I think because this is a sensitive area, anything that we wanted to communicate about work in this area would be with, you know, appropriate feedback from the health directors and others involved in mental health programming.
Just to amplify on that, I think, you know, Shannon's message is pretty clear, and you know, no one's going to violate confidentiality, or certainly if they do, they won't be working very much longer, and no one is going to deliver any messages about communities unless or until it's the community itself that wants the messages delivered. So if that was the sense of one of the senses of your question, I hope that's gives you some satisfaction or helps you relax about that. If it's a broader question about further communication, please amplify the question. Let's see if we can do a job of answering that.
I wonder if I could just make a brief comment. I think that's a very good question, and it's a very complex one, actually. I think it really, right now, likely at the local level, there's a lot of different variations of that, but one of the things that we'd like to do is to help community support, and specifically with health directors, we can support in the formation of locally appropriate protocols. And some communities may want us involved, others may not, depending on whether there's a relationship that exists already. Some communities have a relationship with the Regional Health Authority medical officer, and some may choose to sort of handle within their own existing supports within the community. But certainly that's a role where we'd like to assist if possible. But one of the things that we'd like to do, and we've been working on through the Tripartite Suicide Prevention Working Group, is the development of a toolkit to assist health directors in assessment of existing resources and planning for mental health promotion and prevention, and also around some planning for crisis response. And formation of protocols is one of those components of it. I just wanted to say as well, from an organizational perspective, and the reason why I think it's a very good question is that question has just come to us to even sort out internally, because as Shannon mentioned before, sometimes we hear about some communities experiencing mental health difficulties through nursing, sometimes through transfer, sometimes through health surveillance, and sometimes through mental health programs. So we're trying to work on documenting our internal communication protocols so that we're all aware and connected and in touch with each other and can support the communities, and then also what the protocols are for connecting externally. So that's something that's work that's ongoing, and certainly your feedback and input into how we can make it more useful to you would be appreciated. Thanks.
So are there any more questions in the video conference? Any more comments or questions? Because we are at the 3 o'clock time frame right now. Time has gone really fast today.
Looks like everybody's awake.
I wonder if I could just say thank you to everybody who's come to listen to us today, and we hope this is just the start of an ongoing relationship, because we're really, when we hear from you, it gives relevance and meaning and direction to our work. And I also just wanted to say, well, thank you to the Learning Circle staff and also to Christine for opening up that connection with us. So thank you. We hope this is the start of an ongoing relationship.
Yes, any final comments from?
I would just agree with what Naomi has just said, and to tell you that it is a delight to be in contact with you this way, if not in person. Sitting in an office in Vancouver isn't always the best way to get to know what your expectations are. So I very much value this opportunity, and as I said, I hope it's the first of many, many to come.
Yeah, I would echo what Naomi and Isaac said, and I think also Christine Stoller had also mentioned potentially about like the physicians having a somewhat of a visible face on the website for the health directors, and that being another way that we can communicate with you as a group, potentially future Learning Circle sessions. So if people felt like this was useful, we could have another session, just a general question and answer, or if there was specific things that people would like us to try and talk about. And of course, getting out to regional planning sessions potentially, or at Gathering Wisdom, like the face-to-face is always a really great opportunity as well. So yeah, and I think these are great questions that people have asked today, and some of them aren't easy, and we know there's a lot of questions that aren't easy that we're going to be looking at over the next while.
Great, thank you. Thank you so much. I say Kukjem, my Shuswap side, Haichka, my coastal side. And for the future, what we have up and coming sessions, please definitely keep an eye on the UBC Learning Circle website and follow us on Twitter and Facebook. So for up and coming sessions that we have Elder Jerry Ullman, Decolonizing Ourself. Jerry presents a special learning circle on the impacts of colonization on me, my family, my community, and healing the impacts of colonization. The Learning Circle will enable participants to engage in a dialogue about the impacts of colonization on health and provide a safe space to facilitate the process of healing. And that's Monday, May 22nd from 10 to 12. And on Monday, May 27th, some of the Learning Circle staff will be traveling to the Tanaka Nation, and there will be a Learning Circle on the epigenetics and Tanaka knowledge and relationships. These sessions, it's a day-long session, so there's sessions throughout the day, will bring to the forefront questions about how to bring Western science and methodologies into use for Indigenous people in health and well-being, while supporting deeper understanding of Indigenous peoples' knowledges passed down from previous generations. Overall, the intent is to support Indigenous peoples to consider what knowledges are needed in their efforts for health and well-being without giving up their grounded approaches to the knowledge and its relationship in research. So the keynote speaker is Dr. Michael Yellowbird, and his title of the workshop he's presenting is Neurodecolonization, Deleting the Neural Networks of Colonialism. This presentation discusses the emerging Indigenous science referred to as neurodecolonization, which focuses on how cultural traditions can be used to positively shape key neural circuits of the brain to improve health and well-being. The traditional and contemporary cultural ceremonies that include practices such as mindfulness, optimistic thinking, and creative imagery. They are important approaches in neurodecolonizations. And on Wednesday, May 29th, from 1 to 3, we have 2 presentations in that time period. We have the UBC Center of Excellence in Indigenous Health from here at the University of BC. And then we have the Cedar Project partnership coming to present. So the presenters include Dr. Link Kessler, Chief Cookie Wing Christian of Spletson, Leah May Walker, and Margot Pierce and Vicki Thomas. So the UBC Aboriginal Health Strategy Working Group will present on the proposed UBC Center of Excellence in Indigenous Health, and the Cedar Project Partnership will present on their multi-year community-based research project that will address the impact of historical trauma, specifically parental attendance at residential schools, on the health of the young Aboriginal people who are at risk for HIV and hepatitis C. So please do join us and follow us on the UBC Learning Circle website. And thank you for attending and participating in today's session. So have a good afternoon, and thank you again. Have a good day, everyone. Thank you.